Hi, my name is Annabelle Tang. I'm from Maggie L. Walker Governor School in Richmond, and my project seeks to evaluate the correlation of the National Institutes of Health stroke scale with emergent large vessel occlusion in stroke alert patients. So I chose this research project because stroke and large vessel occlusions in the brain have extremely significant impacts for overall patient health. And stroke is the fifth leading cause of death for Americans. And more specifically, large vessel occlusions in the brain account for nearly half of those strokes. Unfortunately, the only treatment for large vessel occlusions right now that is widely used is endovascular treatment. So all stroke patients have to be screened by CT angiography, and in the vast majority of LVO cases, a thrombectomy procedure is done, where a catheter is inserted into the patient's blood flow to remove the blockage and restore that flow. However, while CT angiography is extremely effective in detecting LVO, this technology is still very costly for patients, especially those who are uninsured, and the process itself can be even physically harmful in some cases. So, for example, patients can have allergic reactions to the contrast. They can be affected by overexposure to the radiation that's used in CTA. And sometimes the medication that is given to these patients to supplement the CTA can also have side effects. Additionally, in developing countries, non-contrast options may be the only choices at primary stroke centers, and centers may not have access to CTA. So given all of these problems, it's really critical to look for another method of stroke diagnosis that is reliable and effective. One such method is the National Institutes of Health Stroke Scale, which is the most commonly used clinical score to assess the severity of deficits in stroke patients. So the NIHSS is an assessment that's given by stroke neurologists for every patient after stroke symptom onset, and it measures factors such as the patient's level of consciousness, facial movement, and motor abilities. So a higher NIHSS score indicates a more severe stroke and consequently a higher indicator that an LVO is present. The NIHSS is a very good predictor for patient outcomes, but it's just not typically used to diagnose LVO in stroke patients because of a lack of research in this area. So instead, a CT angiography is typically done. So here you can see an image of occlusion in the brain. And on the left side, you can see the blood flow from this artery is cut off, whereas on the left side, it's continuing into the rest of the brain. And you can also see the same on this other image over here, where the blood flow is just not reaching the brain on this right side. So this brings us to the purpose of this project, which was to evaluate the feasibility of using NIHSS to predict LVO in VCU stroke alert patients. Prior literature from a similar study conducted by Heldner et al. And Adams et al. Among a national sample size indicates a strong correlation between the NIHSS and LVO diagnosis as a baseline predictor of vessel occlusion severity, but with the association being best within the first hours after symptom onset. So these resources from this prior literature was very helpful when designing my experiment because they provided a baseline for a setup. The premise of this project is that stroke patients with very low NIHSS scores of say 1 or 2, that they'll have very little chance that they will have an LVO, and therefore they won't necessarily need CTA imaging. This would bring down the cost attributed to CTA, and it would also eliminate any negative side effects of CTA for these patients. And it would also reduce hospital capacity and increase the supply of resources, which is especially essential given an increased strain on the medical center this past year. This study was conducted center-specific to the VCU Medical Center, which currently completes a CTA for every stroke patient, regardless of their stroke symptom severity. And given previous studies that have been completed on a larger scale, the hypothesis in this experiment was that these two factors would be positively correlated, determined by Pearson correlation. The two groups in this study were split into those who had LVO and those who did not, and that was determined by CT angiography. The experimental group in this study was the 82 patients presented to the VCU Stroke Center from January 1st to September 30th who were found to be positive for LVO. And the control group was the 211 patients who presented with a stroke alert with negative LVO and CTA. For the positive LVO group, the volume of the ischemia was also estimated using rapid software. The NIHSS of both groups were compared using t-test. ROC analysis was used to determine the best NIHSS cutoff to distinguish these two groups, and the severity between the NIHSS and the size and severity of the ischemia was assessed using Pearson correlation. What I found was that the LVO group had a significantly higher NIHSS than the non-LVO group, which indicates that the NIHSS score is positively correlated with the presence of ischemia. So in other words, a higher NIHSS means that there's going to be a higher likelihood that the patient will have LVO and a larger ischemia, which this is to be expected, and this is in line with what previous research has also indicated. However, this study found that NIHSS cannot be solely used to distinguish these two groups because there was still a significant overlap in the NIHSS score between the two groups. So 22% of positive LVO patients still had an NIHSS of 5 or less, which is relatively low. And 8% of non-LVO patients had an NIHSS of greater than 20, which is extremely high. And this would definitely cause issues if these patients weren't screened on CTA. And this is a contrast from the literature that I cited, and it represents a significant deviation from what is to be expected. I also found that although the NIHSS had a moderate correlation with the size of ischemia, ROC analysis failed to identify an NIHSS cutoff value with acceptable sensitivity and specificity. So while these two factors were positively correlated, we couldn't find a specific NIHSS score where we could say that all patients with an NIHSS score below this number don't need to have CTA. So for example, the best cutoff for distinguishing these two groups we found was an NIHSS of 10, which had 80% specificity and 50% sensitivity. What this means is that among patients who have an NIHSS score of 10 or higher, 80% of the time, this score will be able to correctly identify patients without LVO. However, it will only be able to identify patients with LVO 50% of the time. What this graph shows is that patients who had LVO, which is a positive group on the right side, they had a generally higher mean NIHSS, which this tracks with previous research and the hypothesis. However, this graph shows the complexity of this reality. So although the general trend line shows that a higher NIHSS corresponds to a higher chance of having LVO, we see a lot of these individual cases that just don't follow the same pattern. So for example, this case over here, this patient has a very low NIHSS score, around 1 or 2, but the size of the ischemia is abnormally large when you compare it to the mean that's displayed on the trend line. Right, so when you look at many of these cases, it's just difficult to generalize a conclusion. And one possible explanation for these outlier cases is that sometimes a small minor stroke can happen in a very important area of the brain. So say, for example, a minor stroke occurs in an area of the brain where motor movement is heavily affected. The stroke is still going to have very large implications because it's in that important area and because the patient's motor abilities would decrease. This would heavily affect their NIHSS score, but that just isn't going to translate when you're looking at things such as the size of the ischemia on CTA, because technically it's still a small stroke. And the same thing could happen for larger ischemia. You could have a large stroke in an area that doesn't affect or isn't reflected on the NIHSS. So that is one possible explanation for this effect. In conclusion, we found that while NIHSS is positively correlated with the presence of LVO and CTA, no optimal NIHSS threshold can be identified to detect LVO patients with acceptable sensitivity and specificity, and vascular imaging remains essential for all patients suspected of acute stroke, regardless of their symptom severity. So the hypothesis was rejected in this experiment. This result was slightly unexpected, but this also indicates the critical need for the development of another method of treatment for LVO for stroke patients, as well as just the vast variability that can take place in investigating new methods of treatment. So what this study demonstrated was that regional results specific to the VCU Medical Center were slightly different from results found on a national scale, and that treatment really needs to be tailored to the population that it is serving. Possible errors within this study include that the data was recorded by hand, And the data within this study was collected throughout 2020, so the VCU Medical Center may have been impacted by COVID-19 conditions as well. Possible future applications involve expanding the demographics of this study and utilizing data over a larger period of time. So this would include a larger number of patients. And another avenue that could be explored is studying the effectiveness of NIHSS to predict LVO in relation to time, because effectiveness of the correlation between these two factors were found to deteriorate after the time after symptom onset increased within those national studies that I mentioned earlier. Overall, though, this study was a very beneficial learning experience, and it demonstrated the uniqueness of these medical center stroke treatments, as well as the importance of finding new methods of treatment for these LVO patients. All right, that is my presentation. Thank you so much.